my mouth doesn't say it, my face definitely will. This is only possible with the help of muscle of expression of face. And today I am going to discuss anatomy of face and its applied. Muscles of facial expression and muscle of face, they are categorized on the basis of their region, that is around eye, around nose, around mouth, around ear and coming from the neck. Muscles around eyes. Our eyes are as watchful as the soldiers is standing on frontalis. Front, that is frontalis muscle. LOC, levator palpebrae superioris. O for orbicularis oculi and C for corrugator supercilii. Muscles around nose. Nose is so cute of panda. Panda, P and D. That is procerus, nasalis, that is compressor and dilator, and D for depressor septi. Around mouth, or now biryani majedar. Or, that is orbicularis oris. There are three muscles from mouth, that is levator labii superioris, levator anguli oris, and longest named muscle in our body, that is levator labii superioris and aquinasal. Biryani, that is vaccinator. Majedar, M-Z-D-R. M for mentalis, Z for zygomaticus major and minor. D is depressor anguli oris and depressor labii inferioris, and R for risorius. Muscles of auricle, auricularis anterior, auricularis posterior and auricularis superior. And muscles from neck is the platysma. We will discuss origin, insertion, action, nerve supply and its clinical significance. First coming to frontalis muscle. In scalp we have discussed third layer is the gallia aponeurotica. Aponeurotic layer, scalp, S-C-A-L-P. So third layer is gallia aponeurotica, and from the anterior margin, frontalis muscle. Here is the anterior margin, frontalis muscle takes its origin. The superficial lamina is attached to the skin over the supraorbital margin and the root of eyes. And the deeper lamina is attached to the muscle over there, that is orbicularis oculi, then corrugator supercilii and procerus. And it is connected below. Action. This is the era of ADBUS, that is advanced technology bus. AT, AVUP contraction. AVUP part contraction of the frontalis muscle give rise to expression of terror at, and below part contraction will give the expression of surprise, just like this, and terror. And very important, the clinical significance, that it has got no bony attachment. That's why a blow to the skull, blow to the eyeball, and and fracture of the roof of the temporal plate, roof of the orbital plate of the frontal bone, that will lead to extravasation of blood collect around the eye. Collect around the eye. Yeah. And that will lead to black eye. We have discussed it. Coming to second muscle, levator palpebrae superioris muscle. It is around eye, but not the muscles of facial expression. And also short note has come in university exam. This is very important muscle, levator palpebrae superioris. It has got two components. This in green color, this is somatic component, and just below that is the sympathetic component. It takes its origin from the inferior surface of the lesser wing of sphenoid. Here it is, and get inserted by the three lamina, that is, here it is, this one is levator palpebrae superioris muscle, then it convert into tendon and get inserted intermediate lamina and the deeper lamina. Superficial lamina is going to the skin of the upper eyelid. Intermediate lamina is going to palpebral part of the orbicularis oculi muscle. And the deeper lamina is going to the anterior surface of this white one is superior tarsal plate. So going to the anterior surface of superior tarsal plate. And this one, this muscle is the sympathetic component. It takes its origin from the junction of the muscle and tendon and get inserted over the tip of the superior tarsal plate. Superior tarsal plate is the condensation of superficial fossa. We all know there is no deep fossa in the face. Okay? And all the facial muscles, they are lying in the superficial fossa, and this type of muscles is known as paniculus carnosus. Always asked in the Viva exam, what is paniculus carnosus? Those type of muscle which lies in the superficial fossa. And it can be skeletal muscle or can be smooth muscle. Skeletal muscle is the facial muscle and the palmaris brevis of hand. And the smooth muscle is the dartos muscle of the scrotum and the corrugator cutis ani around the anal region. That is smooth muscle. Now come here. This is somatic component and this one is sympathetic component. This somatic component is supplied by the oculomotor nerve and this is the sympathetic component supplied by the sympathetic nerve. About this clinical significance, when oculomotor nerve palsy occurs, it will get paralyzed levator palpebrae superioris leading to ptosis. And this sympathetic component, also known as Muller muscle, when it gets paralyzed, this will result into partial ptosis. Very important. And involved in the Horner syndrome. Horner syndrome is what? Pamal, ptosis, meiosis and hydrosis and ophthalmosis and loss of pseudospinal reflex. So this is levator palpebrae superioris muscle. Now coming to orbicularis oculi muscle. It takes its origin. This is medial palpebral ligament. Here it is. Condensation of superficial fossa towards the medial corner of the eye. And also it takes its origin from the nasal part of the frontal bone. This is dark orange color. This is frontal bone. And this is the nasal process of the frontal bone. And here in purple color, this is maxilla. And this one is frontal process of maxilla. So, from the nasal process of the frontal bone and frontal process of maxilla as well as the medial palpebral ligament, it takes its origin and get inserted into the lateral palpebral ligament, going superiorly as well as inferiorly. It has got three parts: palpebral part, orbital part and the lacrimal part. Palpebral part that covers the eyelid. Orbital part going over the orbital region. This is the orbital region. And lacrimal part which lies medially over the lacrimal sac. Its action: the soft closure of the eyelid occur due to the palpebral part, tight closure by the orbital part, and compression of the lacrimal sac occur due to the contraction of lacrimal part of the orbicularis oculi muscle. It is the fastest acting muscle in our body, orbicularis oculi. It blinks in 0.1 second. Always asked in the Viva exam, what is the fastest acting muscle? It is the orbicularis oculi because it blinks in 0.1 second. And clinical significance is corneal reflex, in which a swab is a cotton swab is touched over the cornea and the blinking occurs. The efferent fiber MESA, that is motor is efferent and sensory is afferent. So sensory, afferent fiber is going by the nasociliary branch of ophthalmic nerve and motor is coming by the afferent, that is by the facial nerve. Temporal and zygomatic branch. Here is the temporal branch, this is the zygomatic branch. So very useful clinical significance in the corneal reflex. Now coming to corrugator supercilii muscle. Name itself says it helps in the corrugation, that is the wrinkling. Vertical wrinkle in the forehead is only due to the corrugator supercilii muscle. Here it is. It takes its origin from the medial margin of the supraorbital. Here is the supraorbital margin, and this much is the superciliary arch. Supraorbital margin is very prominent in the lateral 2/3. In the medial 1/3 it becomes round. So only lateral 2/3 is known as superciliary arch, and from the medial end of the superciliary arch it takes its origin and get inserted into the lateral aspect of the root of nose. And action is wrinkling, which give expression of suffering and frowning. And clinical significance that by the surgeon it gets paralyzed by injecting botulinum toxin, so that wrinkle will not occur. In case of aged people, due to the loss of elasticity of skin, wrinkle appear very early due to the sun exposure. So it can be lost by injecting a small amount of botulinum toxin into that muscle. Procerus, muscle around the nose, panda, P for procerus, which result into the horizontal wrinkle of the forehead, giving the expression of anger. It originates from the lower part of the nasal bone. Here is the frontal bone, only this much is the nasal bone, and here comes the maxilla. So from the nasal bone and going to the root of nose in radiating fashion. This is procerus. Again, it is also paralyzed by the injecting botulinum toxin in order to get rid of wrinkles. Coming to nasalis muscle. It is of two types, compressor naris and the dilator naris. Compressor naris, it takes its origin from the maxilla. Here it is maxilla, and going to the dorsum of nose. This part is root of nose and this one is dorsum of nose. So from maxilla it takes its origin and get inserted into the dorsum of nose and intermingle with the opposite side of, here these are paired muscle. So this is compressor naris and get intermingled with the fiber of opposite side. And dilator naris, it takes its origin from the maxilla itself and get inserted into the ala of nose. Compressor naris narrows the nasal aperture, whereas the dilator naris, its contraction lead to widening of nasal aperture, and it get affected in cleft lip and cleft palate. Congenital anomaly, this muscle will not develop and get affected in cleft lip, cleft palate. And as this is the superficial muscle, most superficial out of this, so used for the facial nerve testing. And its action we have read, and it is widely used by the swimmers. Inside the water, swimmer used to narrows their nasal aperture. Panda, another muscle around the nose is depressor septi. It takes its origin from the canine fossa. Here lies, incisive fossa, not canine fossa, incisive fossa, just above the incisor teeth. Incisor, canine, premolar, molar. 2, 1, 2, 3. Incisive fossa, from here it takes its origin and get inserted over the nasal septum, and contraction of which lead to narrowing of the nasal aperture. Also widely used by the swimmers to narrow the nasal aperture. Around mouth, orbicularis oris muscle. It takes its origin from the alveolar process of maxilla and alveolar process of mandible and get inserted over the skin of lip, orbicularis oris. It is also known as kissing muscle. Its action is to narrow the oral aperture. Coming to levator labii superioris. It is also known as caninus muscle. It takes its origin from the medial part of the infraorbital margin. This is infraorbital margin. And the medial part of infraorbital margin, it takes its origin and get inserted into skin of upper lip. Levator labii superioris. Coming to levator labii superioris eloquenesi. कुछ पूछना चाहते हो? पूछना चाह रहे हो? Levator labii superioris eloquenesi. It takes its origin from the lateral aspect of the nasal part of the frontal bone and get inserted in two lamina. One lamina is going to the aloft nose and another lamina is going to skin of upper lip. So its contraction lead to elevation of aloft nose as well as skin of the upper lip and give expression of head. Coming to levator anguli oris. This muscle takes its origin from the canine fossa, which is just below the infraorbital foramen. Here lies infraorbital foramen. Below the infraorbital margin, there is a foramen from which infraorbital nerve is coming out. And just below that is a fossa that is known as canine fossa. From here it takes its origin and get inserted over the angle of mouth. This is levator anguli oris. Very important clinical significance of these two muscles, levator anguli oris and the levator labii superioris. In between these two, there is, when we will read tissue spaces of face and neck, then we will go through it. There is caninus fossa, which is in between these two muscles and widely used by the dentist to desensitize the infraorbital nerve for doing surgery over the cheek and the tip. Coming to buccinator muscle, it takes its origin from the posterior part of oblique line situated on the anterior surface of the mandible. On the mandible, there is an oblique line on the anterior surface of the body and ramus from the posterior part, and this one is pterygomandibular raphe. And from the pterygomandibular raphe, this buccinator muscle takes its origin and get inserted into the orbicularis oris muscle. It is also known as trumpet muscle or blowing muscle. Coming to mentalis, it takes its origin from the mental protuberance of the mandible and get inserted into the skin of lower lip. Give the expression of doubt. Zygomaticus major muscle or a smiling muscle. It takes its origin from the posterior part of zygomatic bone. Zygomatic bone has anterior surface and the lateral surface. From the lateral surface, it is not so appropriate picture. From the posterior part of the zygomatic bone, from here, it takes its origin and get inserted into the angle of mouth. Zygomaticus major muscle. Widely used in the reconstructive surgery of face. Zygomaticus minor. Minor is always protected by major. So in green color, this one is zygomaticus minor, which takes its origin from the anterior part of the lateral surface of zygomatic bone and get inserted over the skin of upper lip. Both are smiling muscle, major and minor diagrammaticus. Coming to depressor labii inferioris. It also takes its origin from the anterior oblique line. This one is mandible, and on the anterior surface of mandible, this is anterior oblique line. So from the anterior part of the anterior oblique line of mandible, it takes its origin and gets inserted into the skin of lower lip. Depressor labii inferioris. As its name itself says, it depresses the lip, lower lip. Depressor anguli oris. From the anterior oblique line, just posterior to the depressor labii inferioris, it takes its origin and get inserted into the angle of mouth. Depressor anguli oris. Oris means mouth, angle, and it depresses. Takes its origin from the anterior oblique line, just posterior to the depressor labii inferioris, and it has got very clinical significance. DAO means दाव. बंगला में होता है दाव मतलब दो. दाव आमाते हैं, मुझे दो. तो दाव हो गया, तो लो कैच कर लो. तो उससे एक हिंट मिल गया. कैच 22. It is in this muscle get affected in congenital anomaly, that is CAS 22. C for cardiac anomaly, A for abnormal facies, T for thymic hypoplasia, C for cleft palate, and H for hypocalcemia. Occurs due to the deletion of 22q11 chromosome, and this is the muscle of frowning. Risorius. It takes its origin from the parietodomasseteric fossa, the only deep fossa in face. Our face has got no deep fossa, but only present in the as the form of parietodomasseteric fossa. From here it takes its origin and going to the angle of mouth and orbicularis oris muscle. Risorius. Coming to muscle around the ear, auricularis anterior. It takes its origin from the superior temporal line. Here lies the superior temporal line in the temporal bone. From here it takes its origin going to the anterior aspect of the auricle. Here lies the root of helix. So anterior. And its action is to elevate the auricle. Auricularis superior, just posterior to that, from the superior temporal line itself, takes its origin going to superior aspect of the auricle. Auricularis posterior, from the anterior surface of the menstrual process going to the posterior aspect of auricle. Platysma muscle, very important. It takes its origin from the infraclavicular fossa as well as the supraclavicular fossa. This one is clavicle in the middle, and from the infraclavicular fossa and supraclavicular fossa it takes its origin and get inserted over a wide region. And this muscle is very much similar to lamb. So lambs, it get inserted over the lower lip. A very much sound like O, so orbicularis oris. M for modiolus, B for base of mandible, and S for skin of cheek. Over this wide region it get inserted. What is modiolus? Anyone? Modiolus. Sometimes short notes come on this. Modiolus. It is a chiasma, that intermingling of 8 facial muscles. चैनल पर डाले हुए हैं, देख लीजिएगा. और नाउ बिरयानी जोरदार. ऑर्बिकुलरिस ओरिस, चुप कर लीजिएगा. और नाउ बिरयानी जोरदार. मोडियोलस. It help in the speaking, swallowing, and it stabilizes the lower dentures. Very important. Modiolus lies 1.25 millimeter lateral to the angle of mouth. Here lies modiolus. And this is is parotid gland, greater auricular nerve, lesser occipital nerve, external carotid artery, external jugular vein, and mandibula is mandibular division of the facial nerve. All these are structure. Just when we dissect platysma and remove it off, then these structure become visible. Motor nerve supply of face. Just like a slap over the cheek. This thumb symbolizes temporal branch. These are the 5 terminal branches of the facial nerve, motor division of the facial nerve. Teju BMC, temporal branch, diaphragmatic branch, buccal, marginal mandibular, and cervical. And the muscles overlying there, that is upper part of the orbicularis oculi, corrugator supercilii, procerus, frontalis, all these are supplied by the temporal branch of the facial nerve. Zygomatic, lower part of the orbicularis oculi, hairline, zygomaticus major, minor, some part, as well as the compressor and dilator, nares, all they are supplied by the zygomatic. Buccal, muscles around the upper lip, marginal mandibular to at this side, all depressors, and platysma is supplied by the cervical branch of the mandibular nerve, cervical branch of the facial nerve. Now, coming to the diagrammatic representation of the facial nerve, only we will discuss the motor component. In green color, this one is the motor component of the facial nerve. It lies in the lower part of the pons. First is take reverse force. It is not shown here. First is take reverse force and create around the abducens nucleus and create a impression over the floor of fourth ventricle, that is known as facial colliculus. And then it progresses after coming out at the level of pontomedullary junction, and it runs in the internal auditory meatus, where most medially, motor nerve is most medially. It is not a proper diagram because all other component of the facial nerve, they constitute nervous intermediates which lies in the intermediate position. Most medially is the motor nerve, motor component. Then comes nervous intermediates which constitute both parasympathetic as well as the taste fiber and all other fibers. And then comes most laterally is the vestibulocochlear nerve and the labyrinthine artery. Very important. Always ask in the Viva exam. Tell me the positions of the facial nerve. The components of the facial nerve. What is the arrangement inside the internal auditory meatus? Most medially is the, and for medially, and for motor component. So most medially. And rest fiber of the facial nerve constitutes nervous intermediates. Name itself says, I am lying intermediate. So intermediate, in the middle is the nervous intermediates, and then most laterally is the vestibulocochlear nerve plus labyrinthine artery inside the internal auditory meatus. Then it comes to geniculate ganglion, enter inside the facial canal, first in the vertical part, then in the horizontal part, and then coming out, this in green color, through the stylomastoid foramen. We have already, people have already gone through this facial nerve. So this is the stylomastoid foramen. Before coming out from the tympanic cavity, these are inside the tympanic cavity. This facial canal lies inside the tympanic cavity or middle ear cavity. Inside the middle ear cavity, it gives one branch that is nerve to stapedius, going to the shortest muscle of our body, that is stapedius muscle. What is longest limb muscle in our body? Animal? Longest name. Not I am asking longest muscle. Longest named muscle. Levator levi superioris electronesi. This muscle. And longest muscle is sartorius. Widest muscle is latissimus dorsi. Largest muscle is gluteus maximus. Strongest muscle is masseter. Fastest muscle is orbicularis oculi. Non-phatic muscle is the cardiac muscle. And shortest muscle is the stapedius. So, when it comes out through the stylomastoid foramen, first it supplies auricularis posterior and as well as the stylohyoid and the posterior belly of digastric. Then it enter into the substance of parotid gland. And after coming out from there, it gives Teju BMC. That is the 5 terminal branch of the facial nerve. Coming to sensory innervation of the face. Very, very important. Sensory innervation of the face by the trigeminal nerve, ophthalmic, maxillary and mandibular. You have to draw this diagram in your university exam. Very, very important. But how will you memorize? Just imagine this person is wearing hair band. This one is hair band, which normally a girl wear. This one is hair band. And this is hair clip. This is hair band. Just this person is wearing a hair band. This one is hair band. Okay, going just in front of the ear, and up to this much. This one is the hair clip. How you have to draw? I'm telling that. This is hair clip, and suppose the distal point of this hair clip as well as the hair band is very pricking, and blood is trickling out from this pricky portion. One blood drop is going to angle of eye, one blood drop is going to angle of mouth, and another blood drop from this pricky end of the hair band is going to the angle of mandible. 3 angles. There are 2 blood droplets. One is going to the angle of eye, one is going to the angle of mouth, and another one from the distal end of this hair band is going to the angle of mandible. This how you have to, and by this trickling of blood, this person started crying. And now one teardrop is going in the middle of nose, just like you have to draw. So the tip of nose is supplied by the ophthalmic nerve. Very important. Upper lip by the maxillary, lower lip by the mandibular. Okay, and these are by the cervical nerve, superficial cervical plexus. This one is face, and these are the sensory innervation of the face. Very important. This is how you have to keep picture in your mind. Now coming to blood supply of face, it is by the facial artery. Just come out from the external carotid at the region of the carotid triangle. This is carotid triangle. Antero-inferiorly, this is superior belly of omohyoid. Antero-superiorly, first there is, this one is a stylohyoid, and in green color this is posterior belly of digastric. And most posteriorly, this posterior boundary is formed by the sternocleidomastoid. This is our carotid triangle. And from here, the facial artery is coming out. Our neck has got vertical part as well as the horizontal part. First, this facial artery run across the carotid triangle and then into submandibular triangle or digastric triangle, which lies in between the antebelly of digastric and posterior belly of digastric, and above is the base of mandible. Here is the submandibular triangle. Okay. Now, in a cervical part, it gives branches, tags. Very important. Long question comes in facial artery, in university exam. Long question about its branches, its course, how it runs, how it's going to supply, where it anastomosis. Facial facial artery. Very, very important. So you have to write all this, how it emerges out from the external carotid artery at the region of carotid triangle, then it goes into the submandibular triangle, here it lies. It runs deep to the, this in yellow color is the submandibular gland, salivary gland. It runs deep to, this one is superficial and this one is deep. So it lies deep to the submandibular gland, and here it forms S-shaped loop. Very important, S-shaped loop. And just coming out over the face at the antero-inferior angle of the masseter muscle. Here lies one muscle on the superficial aspect of the ramus of mandible. Masseter muscle, quadrilateral muscle having 4 angles. So from antero-inferior angle it just coming out and give these branches in the face, that is sela. Sela. And in the cervical part, tax. Tax is what? Tonsillar artery. Here it is, tonsillar artery going to supply the tonsil as well as the posterior part of the trunk. A for ascending palatine, name itself says it ascend, then bifurcate into 2. It pierces the superior constrictor muscle and supply soft palate as well as the tonsil. Ascending palatine. Then comes glandular branch. Here it lies, glandular branch. This one going to supply the submandibular salivary gland. Then submental. This is submental artery, the longest branch of the facial artery in both cervical and the facial part. Longest one is the submental artery going to the submental region. Tax. And in the facial part it is sela, that is superior labial, inferior labial, lateral nasal and the angular artery. This angular artery, here it is, angular artery, it gets anastomosed with the inferior division of the dorsal nasal artery. Here it is, dorsal nasal artery. Dorsal nasal artery is the terminal branch of the ophthalmic artery. Here lies the ophthalmic artery, one of the branch of internal carotid. And there are 2 terminal branch of the ophthalmic artery, that is dorsal nasal and the supratrochlear artery. Here you can see this is superior division and the inferior division, dorsal nasal. So inferior division get anastomosed with the angular artery here. Beautiful anastomosis in between the external carotid and the internal carotid. Coming to venous drainage of face, very important. This is supratrochlear vein and this is medial and lateral branch. Form the supraorbital vein, unite to form the angular vein. This is lateral nasal, superior labial, and very important that it is connected to the pterygoid plexus through the deep facial vein. This one is pterygoid plexus. And through emissary vein, it is connected to cavernous sinus. Cavernous sinus as well as this is angular vein. Here it is not shown. They are connected by the superior ophthalmic vein. Very important. Superior ophthalmic vein. And here is deep facial vein. Now this is superficial facial vein and the deep facial vein both unite to form common facial vein, which along with the anterior division of retromandibular vein, this is the common facial vein. Facial vein along with the anterior division of retromandibular vein unite to form common facial vein which opens into the internal jugular vein. This much. Very important. Lymphatic drainage. In a scalp we have read PMO office, Prime Minister office, because scalp is at the upper level. So lymphatic lymph nodes are doing what? They are for the protection. And for the face, senior superintendent of police, that is submandibular, submental and the preauricular. This is the sensory divisions. This is ophthalmic, this is maxillary part and this is mandibular part. Ophthalmic auricular. Maxillary part is going to the submandibular lymph node. And this is ophthalmic, this is maxillary, and this is mandibular. Mandibular is going to the submental lymph node. SSP. Coming to clinical significance. Cavernous sinus thrombosis, very important. First, you should read dangerous area of face. This is dangerous area of face or dangerous triangle of face. It starts from the root of nose, going to the corner of lip. Up to this much in yellow portion is the dangerous area of face. Why? Because the venous drainage of this area is connected to the cavernous sinus. Through the deep facial vein it is connected to pterygoid plexus of vein, and through the emissary vein it is connected to cavernous sinus. And from at this region this is angular vein, and through the superior ophthalmic vein again it is connected to cavernous sinus. So up to from here to here this much is very prone for if there is staphylo and streptococcal infection of the skin. This will travel to the cavernous sinus. This septic emboli is going to the cavernous sinus, leading to embolus formation at those sites. Cavernous sinus thrombosis. Septic emboli comes in the cavernous sinus and lodge there and form a thrombus. That is known as cavernous sinus thrombosis. Name itself says CST, and it hints towards what the symptom will occur. C for cranial nerve palsy, S for sepsis, and T for traffic, that is overcongestion, venous overcongestion. Very important for short nose, cavernous sinus thrombosis. Because the septic emboli comes into the cavernous sinus, leading to the formation of thrombus inside the cavernous sinus, that is known as cavernous sinus thrombosis. And what structures lying over there? These are third cranial nerve, this is fourth, this is 5A, 5B, that is ophthalmic and maxillary. Here lies the internal carotid artery, and here is the abducens, and these are the sympathetic nerve. So third, fourth, and sixth, these are the nerve for the extraocular muscles, which are responsible for the movement of eyeball, involvement of which lead to external ophthalmoplegia. Person cannot move his or her eyeball. That is known as external ophthalmoplegia. You have to write down under the section of cranial nerve palsy that cavernous sinus in its lateral wall lies third cranial nerve, fourth cranial nerve, and in its at the center lies abducens nerve. Involvement of this cranial nerve lead to external ophthalmoplegia, that all the extraocular muscle will get paralyzed, leading to no movement of eyeballs. And first cranial nerve that is going to be involved is the abducens nerve. LARA, lateral rectus abducens. Person is unable to abduct the eye. पूछोगे कि पेशेंट को कि अब हम हिला नहीं पा रहे हैं, cavernous sinus thrombosis का पेशेंट आ जाता है क्लिनिक पे, तो हिला नहीं पा रहे, कहीं भी ऊपर नहीं देख पा रहे, नीचे नहीं देख पा रहे हैं, तो समझ लोगे कि एक्सटर्नल ऑप्थेल्मोप्लेजिया हो गया है, सारा cranial nerve। तो पूछोगे सबसे पहले आपको क्या चीज में हिलाने में दिक्कत, तो साइड में बाहर की तरफ देखने में दिक्कत हुआ था, एब्डक्शन ऑफ आईबॉल, ठीक है ना। लैटरल रेक्टस का काम होता है एब्डक्शन, which is going to supplied by the abducens nerve। तो यही हम बोलना चाह रहे हैं कि सबसे पहले थर्ड, फोर्थ एंड सिक्स तीनों में सबसे पहले जो होता है abducens nerve इन्वॉल्व होता है। तो पेशेंट बोलेगा कि सबसे पहले हमको बाहर की तरफ देखने में दिक्कत आ रहा है, उसके बाद हुआ है कि हम कहीं भी नहीं देख पा रहे हैं, ठीक है। And as for sepsis, that the sign of sepsis, that pyrexia, 3D pulse, feeble and fast pulse, oligo hematuria. These are the feature of sepsis: tachycardia, tachypnea, and venous overcongestion. This thrombus will increase the venous pressure and occlude the superior ophthalmic vein, which is going to drain here. Superior ophthalmic vein and central vein of retina. When you will read the cavernous sinus, the inflow of venous blood is through the, from anterior aspect is by the two channels, superior ophthalmic vein and central vein of retina. When superior ophthalmic vein gets blocked, that will lead to overcongestion over the face. You can see here, overcongestion. The tissue, the venous blood has come, the lymph into the tissue around the eye and the cheek, and also the central vein of retina, that will lead to blindness, complete blindness when they will get involved. We have read this. Now, trigeminal neuralgia. Another clinical significance of the face. We all know the sensory innervation by the trigeminal nerve, and these are the three divisions of ophthalmic, maxillary, and mandibular nerve. And it is so painful that a person no more able to sing duet song. That default, it initiated by the day-to-day activity like chewing, brushing, makeup. थोड़े एक्शन से कि हाँ हम कंघी कर रहे थे, उसी में बहुत एकदम दर्द शुरू हो गया, ठीक है, इन सब एरिया में. लेकिन दिस इज मोस्टली यूनिलैटरल, होगा कि एक तरफ होगा, फिर दूसरे साइड जब होगा, माने कभी दूसरी बार होगा तो दूसरे साइड हो जाएगा. एक ही साइड, एक बार में एक ही साइड होता है. यूनिलैटरल. इट कम्स इन एपिसोड, नॉट कंटिन्यूअस. Episodic and electric shock like pain, and it get intensified with time. The person will get relief by the drug carbamazepine, and if not treated, we have to do surgical treatment. Trigeminal neuralgia. This much, if you will memorize this much is enough. Now coming to Bell's palsy, which is infranuclear facial nerve palsy. After this nucleus, this all fiber when get involved, that will lead to Bell's palsy, but mostly they get involved inside the facial canal. And the causative organism is viral infection, mostly herpes simplex infection. This will lead to facial palsy, that is known as infranuclear Bell's palsy. Look at this. The flower of Dhatura is bell shaped. So what it is to us? These are the sign and symptom of Bell palsy. Dhatura. D for drooling of saliva, because buccinator muscle is not working here. It's not continent. The person modulus, here lies modulus, which is responsible for the proper closure of the angle of mouth. So the fluid will come out, just trickle out from the angle of mouth. That is known as fluid of saliva, drooling of saliva. Dhatura, as for hyperacusis. In the middle ear cavity, it is giving nerve to stapedius. So, intolerance to loud noise is known as hyperacusis. बोले कि एकदम थोड़ा सा भी जोर आवाज होता है तो एकदम बर्दाश्त नहीं होता है, hyperacusis. Asymmetrical smile, mostly it is unilateral, so one side it is working, another side is not working. So there will not be absence of smile, you have to write down asymmetrical smile, because here it is not working and this is working, so this will lead to asymmetrical smile. Loss of taste, because taste fiber is not going by the anterior 2/3 of the tongue, the taste sensation is not going. U-shaped nasolabial groove loss. This is nasolabial groove. We can't. This is not prominent in paralyzed side. Retroauricular pain. When some cranial nerve get involved, there are two types of symptoms. First, there is exaggeration, and then it becomes senseless. So, the person will complain retroauricular retroauricular area. And then last one, dhatura, A for absence of wrinkles, because corrugator supercilii and procerus is not working, that will lead to absence of wrinkles.